technologies going a little bit beyond the acute phase towards the end. So there are my disclosures. So there are, in terms of new treatments, there are not only new technologies, but also there are pre-existing technologies with new techniques that I want to highlight. And I think the first one that deserves further consideration is the use of double stent retrievers. So as you know, stent retrievers, it's now more than a decade-old technology. The initial papers of Trivo and Solitaire were published in 2012, but what is relatively new is that now you have proof through a randomized clinical trial that was performed in Spain, 5 centers in Spain, that essentially compare the standard technique, which is a single stent retriever, with what you call the Y double stent retriever technique. It was a relatively small trial, which was supposed to be larger, but in the first interim analysis, they stopped for early success with a primary endpoint of what you call first pass full reperfusion, which is a TQ2C or 3, so essentially 90% or greater reperfusion after a single device pass. So when you look at the double stent retriever technique, the investigators achieve about 40% recanalization with essentially full reperfusion in the first pass versus with the standard technique that was just 25%. That resulted in statistical significance difference, as you can see here. The mean number of passes dropped from 1.6 to 2.0. That was also statistically significant. And despite the higher complexity of the technique, because essentially having to deploy 2 stent retrievers, there was no increase in the procedure duration. And the safety profile was pretty good with 6.4 versus 4.3% hemorrhage rate. Another technique that many colleagues, very common here in Asia, actually our Chinese colleagues were amongst the first group to publish on this. Our group has also published on, is rescue stenting during thrombectomy. Right? So there was a small period of time after the Mercy and the early generation of the Penumbra device where actually you were implanting stents to treat clots in the brain. Stents are now re-emerging for failed procedures specifically, or for thrombectomy cases where you see very tight stenosis due to intracranial atherosclerotic disease. And in this paper here we saw very different and a lot more favorable outcomes if you deploy rescue stenting when you are failing on thrombectomy versus not. There are ongoing trials and planned trials to specifically look at this technology. Then the 2 technologies that you have that are more established now is the stent retriever and what you call large aspiration catheters. And here is what you call one of these large aspiration catheters. They typically have a size of around 0.70 inches. And then what you can see here is a glass model where or a silicone model where you can see the tip of the catheter, okay, and the looming of what would be an M1 vessel. And you can see here that the diameter of even a 74 catheter is about 1.8 millimeters versus diameter of an MCA vessel is typically a lot larger than that, 2.5 up to 3 millimeters. But we don't deal with diameters, right? We deal with cross-section areas, and when you look at cross-section areas, these large aspiration catheters are actually not that large. In fact, the cross-section of the MCM1 is on average 2.5 times larger than the aspiration catheter. So because of that, we now have new technologies that are looking to extending the size of these catheters, either with a larger catheter tip or with a funnel type device. And by doing so, you achieve 2 key components in terms of clot retrieval. One is flow control. So the idea is, if you have something that is so big in the vessel, you don't have flow going across, and that prevents digital embolization. As you try to retrieve a clot, fragments break, and if there is antegrade flow, you have digital embolization. So that will give you flow control, will decrease the chances of digital embolization. But just as important, or even more important, is with bigger cross-section areas, you get more aspiration force. With more aspiration force, you can actually get full clot injection, which is exactly what you want. So you are now in the age of the mega aspiration catheters. I know there is now a Chinese company that has a 088 technology, again, going from 07, 071 all the way to 088 size. There are two companies in US, one is called Imperative Care, another one is called Route 92, and a company in Ireland called Perfuse that are leading the way in this technology. What you can see here, it's a regular, this is a Sophia catheter, this is a 070 aspiration catheter. You see the clot is so big that many times the catheter can only cord, okay, the clot, it can't really fully inject. Now observe what happens with a 088 catheter. So in situ, you can fully ingest the clot, okay? And perhaps I should show you the two videos now, side to side. Look at the smaller catheter versus the bigger catheter, and you have this phenomenon of full clot injection. Well, the challenge here is with bigger catheters, it's harder to navigate. So it's all the technology that has allowed us to have enough flexibility to be able to take these catheters to the M1. But it is what you think it's going to happen based on in vitro models. As we use these catheters, you can see the catheters of different sizes there, and with the 088, both for hard and soft clots, you should achieve rates of first pass reperfusion that are way above 80%, even in the 90% range, at least in the bench. And I love this graph where you see the 0.07 size going to the 0.09, so 0.88 essentially, and you can see what is going to happen with clot injection, okay? Why this happens, it's always good to understand why things happen. Well, bigger bore, bigger cross-section area, greater aspiration force, but there is also this phenomenon of the strain stress curve, okay? So if you think about like a bath sponge, right? A wet bath sponge, in the beginning it's very easy to strain the sponge with little force, but towards the end you require a lot more force to strain the sponge. So not only with a bigger catheter, you need less, you generate higher force, but you need less force to go to the actual size of the catheter, right? The vessel lumen is the big red circle, the catheter is the yellow circle. So with minimal strain, you can actually fit the clot in the catheter versus a smaller catheter, you actually need a lot more strain, a lot more force, and that catheter can deliver less force. So good explanation here. And here is a comparison of the existing technology 071 with the 088 in the M1, Basel, and ICA. You see obviously these catheters a lot bigger. You see the 088 catheter in the M1, the tip of the catheter is essentially as big as the lumen, so obviously you're gonna have a much higher chance of fully aspirating the clot. Here you can see the catheter actually going past the M1 to treat a residual M2 occlusion, and through the catheter you can put a smaller catheter and a stent retriever. What is the advantage of having that catheter in the M1? You are bypassing the anterior communicating artery. In this way you have full flow control and you don't have antegrade flow to wash debris as you're trying to retrieve the clot. This is, there have been 2 trials in the United States recently presented. This is the result of one of them with essentially 87% reperfusion after 3 passes. Another technology that you have is the funnel catheter technology. Here is the Anaconda device, which is supposed to be used with a stent retriever, the Envy device, and the sedative clot device. And here you can watch a video of the sedative catheter essentially being snake, you call essentially push with no guidance. Then you deploy this funnel. The funnel then dilates, okay, and it accommodates the diameter and cross-section of the vessel. So full flow control, much larger bore with stronger aspiration. So very promising technology. Another very cool technology, another aspiration technology, is cyclic aspiration technology. So essentially right now, you hook these catheters, we are like a vacuum cleaner. So there is a pump, an aspiration pump, you hook them to a pump, and it delivers a static force that does not oscillate. The idea is adding oscillation by having a valve that turns it on and off at very high frequency, like 6 to 12 hertz. And by doing so, you deliver kinetic energy. And this kinetic energy actually improves aspiration and decreases destabilization. Rapid pulse is one of the systems. The Thunderbolt, the number system, is another one. And here you can see regular aspiration on the left with the, it looks like the Pac-Man, right? That aspirates very, very quickly. You can see the right panel there. Same catheter, same pump. You are only adding the circuit that has rapid oscillation on and off for the pump. Okay, so cyclic aspiration, very, very interesting. Again, here is how you do things. You deliver static energy. Why this is better, right? Same pump, same catheter. How you achieve a better result. The reason why you achieve a better result is when you turn it on and off, okay, you create this oscillation which delivers kinetic energy. So it's the addition of kinetic energy to the static aspiration that delivers the better response. And here is a good analogy. This is a drill. You're trying to go through concrete, you can't. Okay? So you try, you can perforate concrete. Okay? Now, same drill. You're gonna go, okay, in hammer drill mode. When you go in hammer drill mode, what you do is micro movements back and forth. And as you do that, we can go through concrete. Now imagine that you are doing as opposed to push, you are pulling the clot, right? So that's what cyclic aspiration is, okay? It's kinetic energy. We have recently published the initial papers, first pass reperfusion, around 60%. Larger trials are about to be started. Another very, very exciting technology is nanotechnology in acute stroke. So this company called Euphrates Vascular had this brilliant idea of coming up with iron oxide nanoparticles. These things are way smaller than a red blood cell, so they can go all the way through the microcirculation. So you put a magnet and you inject these particles, and the magnet attracts the iron particles, and you can see them moving as the magnet attracts them, even through curved segments like our blood vessels. And in the lower panel, you can see the nanoparticles going through a clot. And the beauty here is because they go all the way through the circuitry, we are creating microthrombectomy, okay? It goes and cleans the entire circulation. Here is peripheral arterial disease. This is a case before and after. You can compare the two angiograms, right? And you see that even in peripheral arterial disease with much more organized occlusions, right? You are showing better reperfusions, as you can see here in this scan of the foot showing a lot improved perfusion. So let's try to apply that into the brain. This was actually tried here in Australia for the first time a few years ago. And after doing a few patients with good success results with intravenous injection, the study was stopped because if you inject iron intravenously, you can actually drop the pressure. So the idea now is to go with a microcatheter and inject these particles intraarterial at a small dose close to the clot and use the magnet, okay? And our hope is that we are not only going to achieve macro reperfusion, but you're going to improve micro reperfusion. Many of you are familiar with the concept of the choice trial, right? Where after you have essentially full reperfusion, our colleagues from Spain had the nice idea of injecting intraarterial alteplase. And the premise there is the alteplase will clean up the microvascular bed, the small arteries and capillaries that you don't even see in the angiogram. And as you all know, in this phase 2 study, there was a great hint of benefit. And I think this is really this concept that you have, what I can see in an angiogram is the tip of the iceberg. we know that 95% of the circulatory bed of an organ is actually in the microcirculation. It's beyond the resolution of an angiogram, and maybe this nanoparticle is going to be a way to treat this microcirculation. Another neat technology is a technology that allows us to study clot composition. This is actually work done in New Zealand, and I believe Australia as well, where you have this microsensor that measures bioimpedance and then can give you a notion of whether you have a red clot or in the bottom a white clot. So as you see, as the sensor in the little microwire passes through the clot, it delivers different signals, and it allows you to understand, is this a hard fibrin-rich clot? In which way I may want to use a specific device versus if I have a soft, more easy to deal with red clot in the upper portion. Then you have actually technologies that are not really endovascular, but are worth highlighting. Something that's getting a lot better is the ability of doing imaging in the angio suite. So what you see here, okay, is the old cone beam CT you could do with our earlier generation systems versus the technology that you now have available to do imaging in the angio suite, right? And as we all know now, you have these large core trials showing that even with large cores, we can benefit patients. So perhaps you should actually bypass the CT scanner and take these patients straight to the angio suite to treat them quicker, since the size of the core should no longer be an exclusion for them. And the first trial was the AngioCat trial, was a single center trial of Spain with Mark Ribble leading, and that trial demonstrated essentially a 2 times higher chance of having less disability with going direct to the angio suite, bypassing conventional imaging with CT or MRI, and saving time. So very, very promising. We are doing a multi-center international trial called We Trust, have over 100 patients enrolled, trying to come here to Australia, hopefully. Another neat technology is neuroprotection, endovascular neuroprotection, specifically with brain cooling. We know cooling is a great neuroprotector. It's very hard to treat these patients because you have systemic side effects. But how about if we find a way to just cool the hemisphere that is actually affected by the stroke? So there are companies, and there is actually great data from China as well, showing that this approach may be beneficial, and this company did develop this catheter that will allow us to do that after the thrombectomy, to do regional cooling of the brain and avoid all these side effects you can have. Robotics and telerobotics, we published the first case series of carotid stenting using a neuroendovascular robot. Our friend Vitor Pereira has done aneurysm embolization. So this is a field that it's growing, and it's great. It's good for us because it's a lot more ergonomic, no radiation exposure. But what it's really promised, in my opinion, is not robotics, but rather telerobotics. This is a paper where this operator, 20 miles from the patients, using a robot, place coronary stents to treat patients with heart disease. So it's already, we do have this technology, and I think for a country like Australia, where you have a lot of problems with distances and all that, something like this could be very, very applicable. And then to finalize, I would like to highlight one of the technologies that it's not really acute stroke, it's actually more neuroprosthesis, perhaps to help some of the acute stroke patients, like a lock-in patient. In this case, we have been using the first human experience ALS patients. This is the creation of an Australian colleague, intervention neurologist Tom Oxley. It's called the stent rod. It's essentially a stent in the superior sagittal sinus in the neighborhood of the motor cortex, senses, okay, the EEG of the motor cortex, and you can translate that into computer signals that actually allow patients, as you see here, that may be locked in, to do digital telepathy. Just with their thoughts, they can control a computer. So it's a neuroendovascular brain-computer interface. And you can see here our patient that you treat in Pittsburgh playing video games just with the power of his thoughts. And as he progressing more with ALS, he's actually controlling Alexa. This is actually a lock-in patient that is able to, with his thoughts, control mobile phone and of course communicate what's happening in terms of pain in his knees. And with that, I'll just conclude by saying the future is bright, a lot of progress in the field, very exciting times, and hope to have opportunity to continue to collaborate with many of you in bringing these new technologies to our patients. Thank you so much for your attention.